Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional, anywhere in the world, involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it.
I'm James Kirklin, and it is my great pleasure, along with my co-course director, Dr. Claudia Herbst, and Dr. Hafil Abdulgani, to welcome all of you to the inaugural World University for Pediatric and Congenital Heart Surgery educational webinar. So the subject for today is transposition of the great arteries with intact ventricular septum. During this 2.5-hour session, we are honored to have world-class international faculty members who will discuss the essential aspects of the management and surgery for transposition. Each presentation will last approximately 8 minutes, with 4 minutes reserved for questions from the audience. Please note that in order to maximize your educational experience, all of your computer mics will be muted. However, we encourage you to ask questions through the chat function on your Zoom application. To submit a question, simply open the chat box, select Claudia Herbst, type in your question, and press the Enter key on your keyboard. Also, please note that this program is being recorded and that for the next 30 days, it will be available to you via a link that will be sent to you by email. Okay, before getting started with the actual program, I'd like to introduce Dr. Christo Tchervenkov, founding president and executive director of the World Society for Pediatric and Congenital Heart Surgery, and he will provide you some background information about the World University. Christo?
Thank you, Jim, from University of Alabama, Birmingham. Thank you, Claudia Herbst from Vienna, Austria. Thank you, Hafil Abdulgani from Jakarta, Indonesia. Good morning, North and South America. Good afternoon, Africa and Europe. Good evening, Asia. Good night, Oceania. Dear colleagues and friends from around the world, welcome to this historic day of a dream come true. A dream I have had for more than 10 years that I have shared with many colleagues in the last few years. A dream of a virtual world university that would enhance the education efforts of the World Society for Pediatric Congenital Heart Surgery in pursuing its mission. The realization of this dream had become even more urgent with the advent of the COVID-19 pandemic. and the complete inability to hold face-to-face meetings. The World University will provide educational activity in between face-to-face meetings and provide a precious education opportunity for those from many parts of the world they are unable to travel due to lack of resources. The mission of the World University Pediatric Congenital Heart Surgery is to promote and facilitate access to education of surgeons and allied professionals involved in the care of patients with pediatric and congenital heart disease. We elaborated the motto of the World University, and we came up with the statement of Scientia Undique e Universa, which is translated in the 6 official languages of the United Nations in order: Arabic, Chinese, English, French, Russian, and Spanish, meaning knowledge everywhere and for all. The World University has been an amazing example of collaboration between these continental organizations and the World Society. A questionnaire was sent to the membership of these organizations, which shows strong support for the World University, with 95% agreeing and 5% sort of neutral. What's important to note that there is a worldwide support, as the responders have come from all continents. I've noted that only 10% of the continents of the responders have come from North America. So there's a tremendous thirst for knowledge in the rest of the world. As you can see, there's overwhelming support for all formats, from series of webinars to videos, to virtual library, case presentation, discussion with experts, regional educational needs, specialized areas and controversies. The topics of interest is pretty much everything. It shows a tremendous thirst for education of not only the surgeons, but the entire team, with a strong interest in a wide-ranging selection of topics. The World University Pediatric Congenital Heart Surgery, its constitution and its educational activities are being elaborated with a broad international involvement of individuals from all continents, participating in ongoing discussions of the following: a constitutional council of over 60 members from all continents, a 35-member curriculum committee. Each individual webinar program committee consisting of 3 co-chairs and anywhere between 9 and 17 members planning the program, such as this morning. The World University Pediatric Congenital Heart Surgery is grateful for the involvement and support of the following individuals from the African Society for Pediatric Congenital Heart Surgery and its president, Frank Edwin. You can see the logo, the freshly minted logo of the African Society with the motto, "Together we go far." It comes from the African proverb, "If you want to go fast, go alone. If you want to go far, go together." We're grateful also to the members from Asia and the Asian Association for Pediatric Congenital Heart Surgery with its president, Kisaburo Sakamoto from Shizuoka, Japan. We're grateful to the leaders of the Congenital Heart Surgeon Society, Joe Durrani, President, James Tweddle, President-elect, Emil Basha, Secretary Treasurer, as well as to the European Congenital Heart Surgeon Association with its President, George Saris from Athens, Greece, Morten Helven, Secretary General for Copenhagen, Denmark, and José Fragata, the immediate past president from Lisbon, Portugal. We're also grateful to the members of the Sociedad Latina de Cardiología y Cirugía Cardiovascular Pediátrica, with the President Horacio Capelli from Buenos Aires, Argentina, and past President Nestor Sandoval from Bogota, Colombia. And finally, the leadership of the World Society for Pediatric Congenital Heart Surgery, with the outgoing President Marcelo Jatene from Sao Paulo, Brazil, the incoming President Zohair Al-Khalis from Riyadh, Saudi Arabia, the past presidents, Giovanni Stalin, Padova, Italy, Hiromi Kurosawa, Tokyo, Japan, Richard Jonas, Washington, United States. And I'd like to also mention our great friend, Jeffrey Jacobs, the founding secretary from Florida, United States, and Jim St. Louis, World Database Secretary. I'm not mentioning Jim Kirklin, he's pretty much everywhere. He's the academic leader of the World University. The curriculum committee is led by Jim Kirklin, myself, and Claudia Herbst, with continental co-chairs from Africa, Frank Edwin, Accra, Ghana, Asia, Krishna Iyer, New Delhi, India, Joseph Regata from Europe, Lisbon, Portugal, Kirsten Finucane, Oceania from Auckland, New Zealand, Elizabeth Stevens from Mayo Clinic, United States, and Nestor Sandoval from Latin America, Bogota, Colombia. I'd just like to mention the next two webinars very briefly. Tetralogy of Follow the Basics and Advanced Concepts on October 31st for the basic webinar, and advanced on December 5th. The Tetralogy of Follow curriculum committee or program committee is led by Elizabeth Stevens from Mayo Clinic, Krishna Iyer from New Delhi, India, Siva Kumar Sivalingam, Kuala Lumpur, Malaysia. And finally, I would like to thank the program committee of today's webinar and the individuals I mentioned here. We have had multiple Zoom meetings and emails in order to elaborate the program of the webinar today. Finally, I would like to acknowledge the Montreal Children's Hospital tremendous support over the years, and more particularly the endowment fund of the Montreal Children's Hospital Foundation of Drs. Ivan and Milka Tchervenkov, my late father, who passed away in 1999, and my mom, who will be 88, for whom education was one of the most important things in life. I'm very grateful to my parents. Finally, as we're introducing this dream come true, there's much more to come. Please get involved, participate. The World University is your university. Thank you very much and have a great webinar today.
Thanks very much, Christo, for that very important background information. So let's get started. The first speaker will be Dr. Hiromi Kurosawa, past president of the World Society from Tokyo, Japan. And his conversation will be about the anatomic considerations for simple transposition.
Okay, thank you, Jim. And dear friends and colleagues, welcome to the World University for Pediatric and Congenital Heart Surgery. As a first speaker, I will talk on anatomic consideration of transposition of the great arteries with interventricular septum. Principle of the embryology of the heart is that anterior great artery always arises from the right ventricle. In transposition of the great arteries, anterior aorta arises from the right ventricle, while posterior pulmonary artery originates from the left ventricle. In normal heart, the anterior pulmonary artery goes around the posterior aorta. Therefore, the axis from the left ventricle to the aorta is pushed down and bent. On the other hand, in transposition of the great arteries, anterior aorta is straight, and hence the axis from the left ventricle to the posterior pulmonary artery is just straight. In normal hearts, anterior pulmonary, when you look at the specimen, in normal hearts, the axis from the left ventricle to the aorta is bent. On the other hand, in transposition of the great arteries, The axis from the left ventricle to the pulmonary artery is straight. As a result, it is interestingly, the trabecular septum marginalis, which is the usually seen in the right ventricle in normal heart, appears on the left ventricular outflow tract in transposition. This morphological configuration could result in the left ventricular outflow tract obstruction in transposition of the great arteries. The conduction system is basically similar in normal heart and transposition of the great arteries. However, the angle of the inflow tract and outflow tract in normal heart is just right angle. On the other hand, this angle is very sharp in transposition of the great artery. Furthermore, in transposition of the great arteries, the right ventricle is the high pressure chamber as in tetralogy of Fallot. As a result, the medial papillary muscle complex is hypertrophied in transposition as in tetralogy of Fallot. Then, the proximal part of the right bundle branch is heavily covered by the posterior extension of trabecular septum marginalis, resulting in intramural course. This is minor morphological difference of the conduction system between normal heart and transposition of the great arteries with intact ventricular septum. In transposition with VSD, the anatomy of conduction system is very much variable. If there is a next occasion, I'll show you. When we look at could you back the slide? Okay, this is my slide. If we see the coronary anatomy in transposition with intact ventricular septum, I always use the Schaefer classification because this is very detailed. And in transposition of the great arteries, the anatomy of the coronary artery is very much variable. In our experience, among 16 cases in transposition with intact ventricular septum, 14 cases, which is more than 85%, are Schaefer classification type 1. Remaining 2 cases are type 2 and type 9. So the most cases of transposition with intact ventricular septum have the very simple basic coronary anatomy pattern, so-called Schaefer type 1. In conclusion, because of the straight axis of the left ventricle to the pulmonary artery in transposition, trabecular septum marginalis appears beneath the pulmonary artery in the left ventricle and results in left ventricular outflow tract obstruction. Conduction system of transposition with intact ventricular septum is basically similar to normal heart. Coronary anatomy is mostly Schaefer type 1 in transposition with intact ventricular septum. Thank you.
Thank you very much, Hiromi. I just want to mention that you have the chat function available to you. I'm looking right now. I do not see any. any questions yet, but I would like to start with this question, Hiromi. You mentioned that the trabecula septum marginalis, which is a right ventricular structure in the normal heart, may cause LVOT obstruction in simple transposition. Could you comment for the audience, how often does important obstruction occur, and can it be readily identified on preoperative studies?
Okay, when I study the conduction system, I always use the microscopic section, and in which I found the tissue, so-called the trabecular septum marginalis in the right ventricle, occasionally appears on the left ventricular side. Then I checked the all transposition, and I found the top of the trabecular septum marginalis components just appeared in the left ventricle, where the so-called left ventricular outflow tract obstruction is frequently seen in transposition with intact ventricular septum. But I think that we need a further morphological study to confirm this conclusion.
Okay, well, thank you very much, Dr. Kurosawa. We'll go on to the next presentation now, Dr. Girish Shirali, who is professor of pediatrics at the University of Missouri. He is going to discuss pre and postoperative imaging studies for detransposition. Dr. Shirali.
Good morning, everybody, and thank you for this fantastic opportunity to speak to a unimaginably diverse audience. So I'm an echocardiographer, one of very few non-surgeons, I suppose, on today's call. The goals of imaging and transposition are accurate anatomic and hemodynamic information to facilitate medical and surgical planning, and then postoperatively to work on targeted post-op surveillance. I'm going to be relying pretty heavily during this talk on this wonderful paper that was published in the Journal of the American Society of Echocardiography by Merrill Cohen and a group of fantastic echo folks that talks about the guidelines for multimodality guidelines for imaging in patients with transposition. And what it starts out by emphasizing is that echo is the major diagnostic imaging modality for transposition. And when we talk about preoperative imaging, our focus is to confirm the diagnosis relatively quickly, assess for adequate mixing of the pulmonary and systemic circulations, and then subsequently do a study that looked for associated structural and functional abnormalities. Occasionally, as dictated by clinical status, a complete echo study must be delayed until septostomy is performed to ensure adequate mixing. The levels of mixing can be at the atrial level, the ventricular level, as well as at the PDA. The atrial communication is the most effective, and a balloon septostomy is a good way to ensure stability. A key feature for me as an echo person who also does a lot of clinical work is that the adequacy of the interatrial communication is determined based on clinical criteria, not just based on the size of the interatrial communication. So looking at aspects such as oxygen saturations, acidosis, reverse differential cyanosis are key in deciding who needs a septostomy and who doesn't. If a patient is born with what looks like a large ASD but has persistent hypoxemia, we want to be aware of a couple of anatomic features that might masquerade as a large ASD. One of those is a left juxtaposed right atrial appendage, and the other is left superior vena cava to coronary sinus, where either the appendage or the dilated coronary sinus masquerade as a large ASD. And then there are other more threatening problems, such as high pulmonary vascular resistance or pulmonary vein stenosis. Once a patient has been stabilized, our detailed echo looks for aspects such as VSDs, the location, size, and number of these, the outflow tracts, and then the coronary arteries. This table points out the nomenclature of VSDs and what are currently 4 different classification systems for VSDs. So you could pick your nomenclature system, but use the diagram on the right to decide which one should be called what. Next, we'll go on to the outflow tract. And the primary issue here is the left ventricular outflow tract. The causes of LVOT obstruction include posterior malalignment of the outlet septum, which is typically seen with malalignment VSDs, and then a few other aspects that can occur in patients with transposition with intact septum, such as mitral valve attachments to the basal ventricular septum, a subvalvar fibromuscular ridge, aneurysmal membranous septum that bows into the LV outflow tract because of higher RV pressures, and dynamic bowing of the entire ventricular septum into the LV outflow tract due to RV hypertension as well. Here's an example of posterior malalignment of this thick thumb of an outlet septum that is protruding into the left ventricular outflow tract in a patient who has a posterior malalignment VSD. This is a patient who had very complex subpulmonary stenosis, so LV outflow tract obstruction with an intact ventricular septum due to mitral valve cords. The entire mitral annulus was rotated so that the medial commissure was directly in continuity with the pulmonary valve, and this led to severe tunnel-like subpulmonary stenosis. This is a patient with an anterior malalignment VSD. If you saw this without looking at the great arteries, you'd think about tetralogy of Fallot, but this one, because of the flow-grow phenomenon, is associated with aortic arch, hypoplasia, coarctation, or even an interrupted aortic arch. Next, we talk about coronary artery anatomy. So here's an example of an intramural segment of the left coronary artery. When we image this by echo, we use features such as where exactly does the coronary artery originate. So if it originates eccentrically, then that's more suggestive that it may be intramural. So either an intramural segment or a single coronary arterial ostium have been shown to be associated with early mortality. And then a feature that some of our surgeons find useful is whether the commissures are misaligned. So you see that here, and I just like to describe which one is where relative to the other. Some of our surgeons reimplant the coronary arteries above the sinotubular junction, and they don't find this particular detail useful, and others find it very useful. So we just mention it anyway. Here are the ASE guidelines for reporting. And so I'd like to suggest that every preoperative complete echo on a patient with transposition should include all of these elements and all of these measurements. So echo can help guide surgical options. I like to measure and provide sizes and also Z-scores of both the outflow tracts, the AV valves, the arterial valves, main branch pulmonary arteries, ascending aorta, and the arch. Talk about any structures that might preclude VSD closure, such as AV valves. The caveats being that if you have a pop-off, it might be difficult to use a gradient to determine the degree of stenosis in terms of outflow tract obstruction. And then a lesson that was taught early on in my career was to beware an arterial switch where the neo-aortic valve is smaller than the native aortic valve, because of the flow equals grow phenomenon. Now I'll talk a little bit about post-switch imaging. So we'll talk initially about early post-switch. So the coronary arteries. This is a key feature, but but truly, ventricular dysfunction is a much better marker of coronary arterial patency than echo assessment of coronary arterial flows. And then, so I would suggest either a CT angiogram or a cath if there's any question about coronary arterial stenosis. The next issue is branch pulmonary artery stenosis post Lecomte. These can be difficult to visualize because the patient is athymic and the post Lecomte pulmonary arteries are retrosternal. So we need an experienced sonographer to be able to do this, or experienced operator anyway. And then anastomotic lines, residual septal defects, neo-aortic regurgitation, and dilation of the neo-aortic root. Here's an example of beautiful imaging of post-Lecomte branch pulmonary arteries. Not easy to get this kind of image, especially as patients grow. And then supra PS here, supra AS there. If there is a concern about any issues with coronary artery stenosis and myocardial ischemia, then one of the things that I've learned as an imager is to go back to the op note, pay attention to what the native anatomy was, what the op notes say, and then use other modalities such as stress echocardiography, a CT scan, and cath. The other thing to remember is that transthoracic echo findings are usually quite subtle. So they can just consist of regional wall motion abnormalities or progressive ventricular dilation and dysfunction. And then MRI can be very useful to look for myocardial scarring. There can be problems related to specific operations that have to do with residual septal defects, anastomotic site, stretch, stenosis, failure to grow, and therefore serial study is important, looking at both the main and branch pulmonary arteries and the aortic arch. And then residual outflow tract obstruction, where we look mostly at the plane of the ventricular septum after a Rastelli. So in summary, echo is just about a comprehensive test for preoperative patients. In the early post-op period, this should be early post-op period, we need to be aware of technical limitations of echocardiography, and then in late post-op patients, especially patients who are having clinical issues, also think about the role of advanced imaging. So multimodality approaches are important, where we put the patient in the center, not each individual modality. Comprehensive post-op imaging requires a full understanding of the native anatomy, and to me as an imager, a key aspect is the op report. So I'd like to thank you for the invitation and for your time.
Thank you very much, Dr. Shirali. So let's see if we have any questions. So here's one question. Are there any specific coronary artery findings that you would see on echo that would lead you to request a preoperative angiographic study?
Well, I think that finding I don't know about an angiographic study. I'd like to request a more detailed echocardiographic study if there is this one finding, which is if we see a coronary artery crossing from right to left or from left to right, posterior to the vascular pedicle, so posterior to the pulmonary artery, transversely in the anterior AV groove, then that is suggestive that and if that is associated with an echo finding that says that the coronary arteries are normal, then that's a contradiction, because that's associated with coronary artery abnormalities such as a circ of the right, inverted coronary arteries, single right, single left, inverted coronaries, and so on. So I look for contradictions in echo reporting to help me decide whether additional imaging is needed or not. And quite honestly, in our center, we use CT angiography, and that's been extremely helpful to determine the anatomy of the coronary arteries, if there's any question.
Okay, well, here's another question. relates to fetal echocardiograms. How, it says, do you routinely perform fetal echocardiograms on your patients? And do you have correlations? Do you find correlations between the pre and postnatal findings, for example, related to left ventricular outflow tract obstruction, et cetera?
Well, the outflow tract abnormalities are actually quite a diagnostic challenge for echocardiography, for fetal echocardiography, and so some of the nuances that become crystal clear by postnatal imaging, such as the difference between transposition and between transposition and a double outlet right ventricle, or between a double outlet right ventricle and tetralogy, and so on, sometimes are difficult to image. Um, so I tend to think about fetal echocardiography, especially in the conotruncal outflow tract abnormality kind of a group of patients, as a uh, as a bit of a screening test. And I tend to hedge when I talk to moms and families prenatally about about the fact that we may find something different postnatally. The flows change, everything changes, and things that look like a significant obstruction may turn out to be related to habitus and and a baby that's camera shy. And once they're born, then they can't be camera shy anymore, and we are able to get great pictures. So I tend to be a little bit guarded with with how much how much I would bet on on a, on the on the diagnostic accuracy of a fetal echo. And I don't mean this as a snub to my echo colleagues. I also hope none of them are listening, because I'll, I'll get into trouble with them. But I know this is a friendly crowd, so.
So one other question. Here's a question: how to distinguish between hyperdynamic LVOT versus actual left ventricular outflow tract obstruction?
It's a great question, and I think that the I would say that the first thing that I would try to do is figure out why the LVOT is why the left ventricle is hyperdynamic. Why is the baby tachycardic? Is the baby not mixing adequately? Is there something that needs to be resolved first? The second is this an early diagnosis or a late diagnosis of transposition? We don't deal with late diagnosis hardly at all in the US, and I would defer on that question to Dr. Iyer and Dr. Kumar from India, who have done fantastic work with late diagnosis of transposition. So I would just suggest that that patients we just try to achieve hemodynamic stability first. Ensure that the patients are mixing adequately, that their heart rate is stable, and then re-image them, and then see what you get.
Okay, great. Thank you very much. And of course, we're going to hear more a little bit later in this webinar about late presentation of transposition. So let's go on to the next speaker, Dr. Cheul Lee from the Department of Cardiothoracic Surgery at the Catholic University of Korea in Seoul, South Korea. And Dr. Lee is going to talk to us about the preoperative management and optimal surgical timing for simple transposition. Dr. Lee?
Thank you, Dr. Kirklin. I'm privileged to be a part of this historic educational event of the World University. My talk will focus on preoperative management and an optimal surgical timing for transposition of the great arteries with intact ventricular septum. Okay. Sorry. Okay. In 2017, the European Societies of Pediatric Cardiac Surgeons and Cardiologists published a comprehensive guideline for the management of patients with transposition and intact ventricular septum. I believe that this guideline can be a good starting point and an excellent reference for my talk. Regarding the site and timing of delivery, because babies with transposition require immediate management after birth, it is recommended that delivery takes place at a tertiary care pediatric cardiology and cardiac surgery center. And vaginal delivery at term is recommended for most patients, whereas cesarean delivery is recommended when high-risk features are identified. Preoperative monitoring includes pre- and postductal pulse oximetry, continuous ECG, non-invasive blood pressure, respiratory rate and pattern, urine output, blood lactate level and NIRS for the decompensated babies, and umbilical venous and arterial lines as needed. Initial management of newborns with transposition should focus on optimizing intercirculatory mixing and adequate tissue oxygen delivery. Because of the presence of parallel circulations, the immediate priority after birth is to determine whether the mixing between systemic and pulmonary circulations is adequate. So immediately after birth, intravenous infusion of prostaglandin is recommended to maintain ductal patency until all sites of intercirculatory mixing have been evaluated. Balloon atrial septostomy may be needed in the presence of a restrictive ASD, although many centers now prefer to proceed directly to arterial switch operation in this situation. Adequate mixing between systemic and pulmonary circulations usually result in arterial oxygen saturation of 75 to 85%. Measures to increase systemic oxygen saturation and tissue oxygen delivery include prostaglandin infusion to maintain ductal patency, balloon atrial septostomy to increase intercirculatory mixing, hyperventilation and increase the fraction of inspired oxygen, transfusion to increase oxygen carrying capacity, sedation and paralysis to decrease oxygen consumption, and inotropic support to increase cardiac output. Regarding nutrition, infants with adequate mixing without prostaglandin infusion should be fed enterally. And hemodynamically stable newborns should be fed enterally as soon as it's feasible, even while they are on prostaglandin. The arterial switch operation, which was first successfully performed by Dr. Jatene in the mid-1970s, is a current standard operation for transposition with a prepared left ventricle. I will not go into the technical details of the arterial switch because the next two speakers are going to deal with these issues. Timing of arterial switch is very critical because the LV has to work at systemic pressure after the operation. At birth, the LV muscle mass is equivalent to that of the RV. Subsequently, as a result of the rapid decrease in pulmonary vascular resistance, the LV soon becomes deconditioned, losing muscle mass and the ability to function at systemic workloads. Currently, the optimal timing of arterial switch for transposition with intact ventricular septum is established from the first few days to 3 weeks of life. Some centers do this operation on the first day of life and reported excellent outcomes. In this study, 21 patients underwent arterial switch at mean of 11 hours after birth without hospital mortality. In another study from Russia, 8 patients underwent arterial switch at mean of 17 hours after birth without hospital mortality. This study emphasized that there was no need for the balloon atrial septostomy to stabilize the patient. However, whether this very early approach is justified for all patients remains controversial. In this study, which examined the impact of surgical timing on postoperative morbidity and hospital cost, delay of arterial switch beyond 3 days was significantly associated with increased morbidity and healthcare cost. In another similar study, earlier repair was associated with decreased resource utilization and no detriment to clinical outcomes. Although most surgeons now perform arterial switch within 3 weeks of life, the upper age limit for primary arterial switch cannot be determined. Although the choice of surgical treatment for late presenters is controversial, current evidences indicate that primary arterial switch should be considered up to 60 days with mechanical circulatory support backup. According to this study from London, neonates at high risk or late referrals can benefit from delayed arterial switch even beyond age 2 months. However, the need for mechanical support in some of the older patients may limit the widespread adoption of such a strategy. I believe it is reasonable to adopt an individualized management strategy for late presenters, taking into account patient and institutional factors. Another challenging situation arises when there are major prematurity and very low birth weight. Large multi-institutional studies have demonstrated increased mortality in infants weighing less than 2.5 kilograms. An individualized management strategy is recommended, taking into account patient and institutional factors. Management options in this situation include early primary arterial switch, late one-stage arterial switch with postoperative mechanical circulatory support backup, and 2-stage arterial switch operation. This study from Melbourne examined outcomes of the arterial switch in children less than 2.5 kilograms. Early mortality for these children was high. However, most of the mortality occurred in children weighing 2.0 kilograms or less. So in summary, preoperative management for transposition with intact ventricular septum should focus on optimization of intercirculatory mixing and adequate tissue oxygen delivery. Ideally, arterial switch for transposition with intact ventricular septum should be performed within 3 weeks of life. Primary arterial switch should be considered up to 60 days with mechanical circulatory support backup. And an individualized management strategy for low birth weight and premature infant is recommended. Thank you very much.
Thank you very much, Dr. Lee, for this very useful information. I don't see any specific questions yet from the audience. I see one related to details about late presentation, and I think we will defer that question because we have 2 talks about that in a few minutes. So perhaps we'll go on to the next speaker to learn more about the details of the surgical management of simple transposition from Dr. Richard Jonas, who is past president of the World Society and he is from Children's National Hospital in Washington, D.C. Dr. Jonas?
Well, thanks, Jim, and congratulations to you and your team on putting together this outstanding program. It's really a great honor to be a part of it. So I've been asked over the next 8 minutes to talk about technical aspects of the arterial switch operation, which, as we all know, is first undertaken by Girish Shirali in an infant with a VSD. And it was Bill Nord and Aldo Castaneda who, in January 1983, undertook the arterial switch in a newborn with intact ventricular septum. And I think it's fair to say that there were a lot of technical tricks to learn about this operation in the newborn, reflected in the high mortality seen in the red in the first couple of years. But as we learn those tricks, and those of you learning this operation today don't have to learn them yourselves, so it is a technically reproducible operation that can be done with a very low mortality. So let's begin with setup and positioning on the operating table, because I do think this is an important component of the operation. By extending the neck, putting a shoulder roll under the neck, you lengthen the great vessels, you pull them out of the mediastinum, and you have more vessel to work with. And one other personal point, I think it's very important. I've seen far too many neonates have very serious problems, even fatal problems related to thrombosis of the superior vena cava when internal jugular lines are left. And it's really very much safer to place an intracardiac right atrial line. Now, this is an operation that's all about bleeding and hemostasis, and a lot of that bleeding is from needle holes, and the larger the needle you use, the larger the needle hole bleeding will be. So use very small needles on 6-0, 7-0, 8-0 operations. Use meticulous suture technique, and that means reinforcing even the most minuscule imperfections in regions you won't be able to get back to. For example, underneath the left coronary artery, that button is really not accessible. If you have bleeding from that point, you're going to have to lift the pulmonary arteries off because of the Lecomte. You'll have to lift the coronary artery, and that will result in ischemia. So be very, very careful and look at those areas. Also, three-way junctions are high-risk bleeding points. You need to avoid tension on a suture line that will turn a suture hole into a suture slit. You need to work with an anesthesia team who are very experienced with optimizing neonatal hemostasis. And don't dilute the red cells, because you also dilute the platelets and the coagulation factors. So maintain that hematocrit above 25. Now, the coronary transfer is obviously very important, and I think marking the transfer site on the main pulmonary artery before you've separated the great vessels and before you've cannulated for bypass is quite important. Where do you mark? Well, it's a simple rotation, not higher, not lower. When you suture the button, make sure you pull the ostium open. It should look circular when you've finished placing the button. Avoid rotation of the aortic anastomosis carefully, and avoid coronary compression, and recognize coronary compression when it's being caused by the overlying main pulmonary artery reconstruction. And just take a tuck in the pericardial patch if it's pushing back onto a coronary button that you've transferred. Now, usual coronaries do vary in position in the sinus of Valsalva, so use a coronary probe as soon as you open the aorta to identify exactly where the ostia are relative to the neopulmonary valve commissures. Sometimes they'll be low in the sinus, even intramyocardial at the origin. Assess the degree of redundancy of the of the coronary at its origin, because that will determine how much you need to mobilize to avoid tension. And once again, look for a slit-like ostium that you can actually improve on. It is possible to improve on the appearance of the coronary artery as you first found it. Divide the aorta at roughly its midpoint opposite the pulmonary bifurcation. We prefer U-shaped buttons. Start much more posterior. It's not just a direct vertical cut. Start posterior. This will leave more of the what is going to be the pulmonary artery for growth of the neopulmonary anastomosis. And the U's can be useful for orientation, and you can discard the tip of the U, which you can use for handling. The pulmonary artery is divided just a little proximal to the right pulmonary artery, and the donor areas, once again, we prefer U-shaped areas. You're going to have to avoid a slit-like ostium. If you cut a V, I think you have more of a risk that you won't be able to pull that ostium out, so it's nice and circular. I think it's important that the coronary buttons almost always lie above the sinotubular junction, because in transposition, there's a subaortic conus, which means that the aortic valve, where the coronaries are coming from, even though they come from the sinuses of Valsalva, where you're going to transfer them to is going to be higher than the neo-aortic valve. And the sinuses are very thin-walled, so I like to stay out of them. I think there's more of a risk of bleeding if you cut into the sinuses of Valsalva. The Lecomte maneuver should be done to avoid tension on the neopulmonary anastomosis. So divide the ductus as soon as you go on bypass with suture ligatures first, of course. Mobilize the pulmonary arteries out into the hilum of each lung. You should be able to certainly see well past the takeoffs of the first hilar branches, and then implant and then transfer the pulmonary arteries. Usually we shift the aortic cross clamp so that it holds the pulmonary arteries back out of the way while the aortic anastomosis is being undertaken. We use a single bifurcated pericardial patch to supplement the coronary donor areas, and it's important to think of this as actually supplementing and enlarging the pulmonary trunk, because neopulmonary anastomotic narrowing is probably the commonest post-operative problem. We used to see a lot of that in the early years, but with a generous patch and leaving plenty of pulmonary artery original aorta for growth anteriorly, and not having tension on that anastomosis from a well-done Lecomte maneuver, you should be able to avoid the problem of neopulmonary stenosis. So here then is the final product. And thinking about some of the more challenging situations, where definitely there are technical tricks. Let's look at intramural coronary artery and single coronary artery transfers. The intramural coronary will often have this appearance. So there's two ostia very close together. One of the ostia, the left coronary ostium, is very close to the posterior commissure. We essentially always divide between the ostia, and times there'll be essentially a single ostium, which means you'll need to suture inside the ostium of the coronary artery. It's thin, and it has to be done very carefully with very fine sutures and very small needles, but that will hold open the anastomosis, and I think that's the safest way to transfer the intramural coronary artery. Single coronary arteries, most situations are actually a benefit for the surgeon. You only have one button to transfer instead of two, but a couple you have to be careful with, and they're circled here. Let's look at them. The coronary artery where there is a single right-sided coronary artery with the left main passing behind the great vessels, this is at risk of becoming under tension, which can cause ischemia. So make sure that you mobilize enough of that left main coronary artery as it passes behind the pulmonary artery. The feedback loop you can get into, if the ventricle is a little bit distended, it's going to pull on that left main, which will cause tension and more ischemia. So once again, make sure you've got enough mobilized up out of the epicardial bed. And really that same principle applies in the other situation where you have a single anterior coronary artery. This is the only situation where you're transferring a coronary artery directly away from the line of the right main coronary artery. As you can see here with the green arrow, you're pulling away from that line. So you may have to mobilize a centimeter, even more of that right coronary artery and its first generation branches up out of the epicardial bed and then transfer it across. And usually you don't need to do anything in addition. Just a handful of times over the years, I've used this maneuver where you extend that coronary to, once again, not have excessive tension on the coronary anastomosis. So just to quickly summarize, use a marking stitch before bypass, avoid rotation of the aortic anastomosis, implant the coronaries above the level of the sinotubular ridge. Make sure the ostium looks circular when your suturing is completed, and mobilize an adequate length of the coronary artery. Avoid compression by the overlying pulmonary artery. So in conclusion, the arterial switch is a technically reproducible operation that really mandates meticulous surgical technique. Once again, thanks for the honor of being part of this first Weld University webinar. I'm happy to take any questions, Jim.
So, Richard, thank you very much for a really elegant presentation in its simplicity yet completeness. I see one interesting question. We have a lot of trainees that are listening to your presentation, and here's one question. In your extensive experience training young congenital heart surgeons, in your opinion, what is the most challenging aspect of this operation to teach young surgeons?
You know, I think of all the operations that we teach, in some ways this is the easiest, because if you follow the principles that I've just talked about, then you're going to get a good result. Like any operation, you have to be very situationally aware. I would say the commonest problem that I've seen people get into is failure to understand why it is, failure to recognize what it is that is causing ischemia. I've really already described by far the commonest issues. But if a child is having any difficulty at all coming off pump, then look for one of those causes that I've described, such as compression by a patch that's a little bit redundant, compressing a coronary artery, or tension on a coronary artery. And it can kink at the point where you've stopped mobilizing out of the epicardial bed where it's being pulled. So recognizing those problems and dealing with them, I think that judgment is probably the hardest part to teach. But the cutting and sewing aspects of the arterial switch are not difficult.
Okay, thank you very much, Richard. So let's now turn to Dr. Marcelo Jatene, who is the current president of the World Society for Pediatric and Congenital Heart Surgery from Sao Paulo, Brazil. And Dr. Jatene is going to discuss the surgical management of anomalous coronary artery patterns. Marcelo? Yes, just Marcelo, make sure you're not muted.
Now it's okay?
Yes, very good.
Okay. So first of all, I just want to thank Jim, Claudia, Christo, and Hafil for the fantastic opportunity to be taking part of this historical moment. It's a great honor and great privilege to be here participating on this first webinar of the World University for Pediatric and Congenital Heart Surgery. When we talk about anomalous coronary patterns, it's very important to reinforce the description of the coronary anatomy in transposition of the great arteries. Many classifications are accepted by most of the teams, the surgical teams, and Yakub and Quaggeber with the Yakub classification, the leading classification 78 and 86 described many different types of coronary anatomies. But one thing that it's important is that we must base that we must say that around 2/3 of the coronary arteries and artery anatomies are considered normal or type 1 or type A when you have two coronary arteries arising from the right and the left valsalva sinus. And all the other patterns are considered anomalous patterns of the coronary arteries. How can we identify an anomalous coronary pattern? Of course, by echo in most of the cases, as Dr. Shirali had just described, or you have a suspicious or a confirmation if you are in doubt about the direction, the trajectory. A CT scan or angiography could be helpful. Of course, there are some disadvantages of the CT scan, the X-ray, sometimes the sedation or anesthesia, and the angiography is a more invasive intervention. So I consider that with the echo suspicious, the intraoperative inspection must always be done, and a very meticulous inspection of the coronary anatomy, trying to find out which is the trajectory, the direction, and which is the direction of the branches of the coronary arteries. So we have some surgical technique considerations. I think Richard had touched in most of the important things, but I just want to complete that you must consider some aspects about translocation technique, if it's open or closed, trying to avoid maximum the kinking or excessive rotation. Sometimes we need to use some techniques to enlarge the ostium, especially in the intramural course, or unroofing, or trying to open the wall, the coronary wall. And sometimes the use of extra tissue can help, as Richard described in one single ostium technique. We have the preference for the translocation technique is the aorta, the new aorta reconstructed. We reconstruct first the new aorta, then we open the clamp, we pressurize the aorta. Prior, we try to identify the position of the commissures, so we can, with the coronary release, we can simulate the best anatomic position with the pressurized aorta. Then I usually place a stitch with the direction and the position, trying to avoid the position where we can have an overlying of the pulmonary artery, trying to put in the lateral wall, and trying, of course, to avoid the commissure and the aortic valve. With the attempt to avoid kinking and excessive rotation, we must release the muscular adhesions and from the right ventricle and the epicardial traject to keep the coronary more free and more easy to transfer, to avoid some fixed positions or fixed points in which you have problems with the transfer. When we have both coronary arteries arising from the same sinus, we have some techniques like placing like a single button with a hood. We must take care with this technique, because the pulmonary artery with the Lecomte maneuver will come over this position, and I always try to avoid this kind of technique, but it's a reasonable one that we can use in some difficult cases. It's not going. Okay. Sometimes we can, this was described by Professor Yakub, when you have, for example, a single coronary artery, you just keep the coronary artery in the same position, make an opening in the new aorta, and when you reconstruct the new aorta, you use like a flap with the distal aorta to cover the coronary artery position, and trying to avoid excessive rotation of the coronary artery. So it's another option, it's another situation. When we have this kind of situation, like a juxtacommissural and with an intramural course, our preference is to divide, should be an option, as Richard has just shown, and or unroof or not, depends on the length of the intramural course and the size of the ostium. So this is a case that we had this situation, and we re-implant in two different positions as if it was two different coronary arteries. We have, of course, higher risk patterns like the intramural coronary artery course, the single coronary with interarterial coronary artery course, some posterior looping courses, and we consider that the intramural coronary arteries are one of the most challenging ones. In many studies are done considering the anomalous patterns. This is a meta-analysis published at the Circulation by Sara Pasquali, and from many very good and very experienced centers with more than 1,000 cases. And we can see that when you have the two coronary ostia, the odds ratio for mortality and for risk for outcome for the operation is close to 1. If you have any type of any variant of the coronary pattern, not the type 1 or type A, you have the double of the odds ratio. And when you have any coronary looping, it's close to 2, the odds ratio. But when you have a single coronary ostium, the odds ratio comes to 5, and the intramural course comes close to 10, showing that there is a higher incidence of unexpected events and outcomes in the specific coronary arteries. Trying to study the intramural and the outcome in the neonatal, this is an experience from Meton, from the group of Pascal Vouet, with close to 1,000 operations. They observed an incidence of 5% of intramural course, and with a very severe impact in the mortality. The other patterns has a mortality, an immediate mortality close to 4%, and in the intramural course, it's close to 28%. It's 7 times when you consider the normal pattern. This is the survival in this specific situation. And freedom from coronary events, in 15 years, you have close to 50%, showing that not only in the immediate post-op period, you could have problems, especially with ischemia, but after, in the late post-op, you can have problems after the coronary transfer in the evolution of these patients. This is one experience that we have at H-Core, Hospital do Coração, close to 200 new children operated, most of them with intact septum. We have an overall mortality around 5%. When we have the type A coronary with intact septum, we have close to 2.3%. But when we have any other type of coronary anomaly, this comes to more than 12% of mortality, showing an impact of the pattern in the outcome of these operations. This is an experience from Dr. Planchet's team, more than 1,300 cases. they observed an incidence of 7% of events, coronary events after the arterial switch operation for transposition. And when the coronary is type B or C in the Yacoub classification versus type A, the odds ratio comes to more than 6. And this is, as we describe it, we not only have immediate events in the immediate course of the post-op, but we can have later events during the follow-up of these children. This is published in the Journal of Thoracic and Cardiovascular Surgery. It's a multi-institutional study from the European Congenital Heart Surgeons Association, published by George Harris, with more than 600 cases of the Jatene operation from 19 institutions. And what they observe is that the coronary type A has a mortality around 3%. And when you have the single coronary, this mortality comes to 11, with an odd ratio more than 3. And if you have other patterns, when you include here the intramural course, this comes to more than 5 of odds ratio. In the opposite side, we have excellent outcomes from the team from Igor Konstantinov from Australia, from 3 different institutions, from Melbourne, from Perth, and from Adelaide, with 28 cases of intramural coronary arteries with no early or no late mortality. And the techniques used were the ones that we have just described. The first 3 patients were the technique that was used. It's just to unroof the coronary artery, and the other one is to divide and to separate in the subsequent patients. And so we can summarize that the complex coronary patterns are related with higher mortality and morbidity. The pre-op definition of the pattern is important, but not really necessary. We can inspect during the operation. The single osteo and the intramural course are the higher risk patterns. Unroofing the intramural traject is used in most cases, and division of the coronaries is very useful. And you can use different surgical techniques and strategy depending on the anatomical issues. Thank you very much.
Thank you very much, Marcelo. We have a couple of questions from the audience for you. The first question is there a coronary artery pattern which would preclude an arterial switch and therefore proceed with the atrial switch operation?
I think so. We haven't done this before the operation. We have done twice the decision during the operation that we are going to the atrial switch, not in the neonatal period because the results are not so good. So we've decided not to go with the arterial switch. We try to open the ASD and keep the child with follow-up for 5 to 6 months and then perform the atrial switch. So in special, the loops, because I think the intramural and the single osteo, we have strategies to fix it. But when you have some very complex loops, when you must release too much the coronary from the ventricle, from the epicardial surface, we have just decided not to go with the arterial switch operation and go to the atrial switch.
So one more question. Here's a question in which there is a notation that the studies on the intramural coronary arteries, you showed a slide by Metten et al., that the survival seemed to be good after an early period if you survive the operation, but it's noted that there continue to be coronary artery events out to 10 years, as you mentioned. What do you think is the mechanism for these late coronary artery events after the switch operation for intramural coronaries?
I think there are some points. I think the biggest impact of the intramural is ischemia. It's acute ischemia because of the unroofing. Sometimes the unroofing is not effective, and we can keep the coronary ostium not so big, and this could represent some ischemia in the immediate post-op. And in the late post-op, it's not different from the other coronary arteries where you can have compression from the PAs when you have overlying, if the coronary is coming beneath the pulmonary trunk, so we can have scars and can have fibrous tissues that can compress the coronary artery. And if it's an intramural traject that you need to cut to one roof, it's a place that you have cuts, sometimes sutures, and compression. So this is, I think, the joint of all these aspects can impact in problems in the future. So I think these are the most common aspects of the problems, the later problems.
Okay, thank you very much again, Marcelo. We'll go on to the next presentation. We do have a few questions that are coming in. I just want the audience to understand that if we have time at the end, I have these noted and we will bring these up at the end. But just for the sake of time, I think we'll move on to the next speaker. Dr. Parvathi Iyer from New Delhi, India, will discuss the management of late presentation of transposition with intact septum. Parvathi?
Thank you, Professor Kirklin and the World University for giving me this honor. So I'm going to speak on the management of late presentation for transposition intact septum. And the outline of my talk would include what is late presentation, implications, surgical options, and our approach to late presentation, as well as the post-operative management of late primary arterial switch. Infants older than 21 days of age, those with regressed left ventricles on echo, and neonates presenting in cardiovascular collapse with or without organ dysfunction are considered to be presenting late. Now, late presenting transposition intact septum still constitutes a very major challenge in low-middle income countries and our part of the world. What are the implications of late presenting transposition? Delayed diagnosis of neonatal heart disease has been shown to adversely impact postoperative outcomes, and there has been a significant increase in in-hospital postoperative mortality, ECLS requirement, and perioperative ventilation. Management of late transposition has been an evolving story globally, and the surgical options constitute an atrial switch or an arterial switch with a focus on anatomic and physiological correction, which may be in the form of a stage procedure or a primary late arterial switch. These recently published clinical guidelines for the management of patients with TGA intact septum have really laid down the recommendations for left ventricular training. Refinements in the two-stage arterial switch has led to vastly improved outcomes in the Western world. However, that's not the scenario in our part of the world. This procedure is currently very unpopular, even though we were early proponents of the rapid two-stage switch. And the reason for this is the stormy, unpredictable intensive care course due to the severe postoperative biventricular dysfunction. So we abandoned this procedure way back in 2006. I draw your attention to this landmark paper, which was alluded to earlier, which looked at 105 infants older than 21 days of age who underwent a primary arterial switch, this paper from Great Ormond Street. And this showed that the left ventricle was potentially adaptable and maintains the potential for systemic work for a period of time, despite a transient and very operative, severe and profound postoperative low cardiac output state. Following that paper, Between 2005 to 2007, we looked at 22 infants with a median age of 55 days who underwent a primary arterial switch, and we used only aggressive afterload reduction with no recourse to mechanical support. And what we found was that the primary and secondary outcomes were comparable to the early switch, with no difference in ventilatory requirements, intensive care, or non-invasive ventilatory requirements. Subsequently, this best evidence topic showed that there was level 2 evidence that primary arterial switch could be done up to 8 weeks of age in experienced units. Thereafter is this paper which showed the clinical guidelines for the management of patients with transposition, which concluded that a primary arterial switch must be considered right up until 60 days of age, but with ECLS backup. So what is our current approach? Since 2002, we've been slowly and tentatively pushing the boundaries of the primary arterial switch. From 2006 onwards, with gradually increasing confidence. So currently, under 2 months of age, we do the primary arterial switch. Between 2 to 3 months, usually a primary arterial switch. And beyond 3 months, a primary arterial switch or ascending with a loose pulmonary band, depending upon the left ventricular configuration, but with minimal recourse to mechanical circulatory support. We no longer do the 2-stage arterial switch. The timing of surgery, however, is of paramount importance for optimal outcomes in our part of the world. And this is because many of the babies present with circulatory collapse, which is often due to a combination of cardiogenic and septic shock. And there's not invariably significant evolving brain injury. So who should we offer surgery to? When should the surgery be done? It's often very difficult to get this right. And this is partly because of the occult preoperative multi-drug resistant gram-negative fungal sepsis and sometimes culture-negative sepsis, all of which lead to increased postoperative mortality, increased postoperative morbidity with length of stay up to 3 months, and huge financial costs. On the other hand, many late presenting transpositions who are much sicker at presentation with profound lactic acidosis and metabolic acidosis seem to fare far better even when they undergo a primary arterial switch, even up to 70 days, with length of stay under 2 weeks, despite significant postoperative LV dysfunction, and the main difference being the absence of sepsis. The other risk factors in our part of the world is the frequency and the severity of preoperative brain injury. All of this has led to our own approach to stabilization of a baby with transposition intact septum. So apart from the standard modalities which have been alluded to in literature, we do a detailed septic workup on arrival as well as a neuroimaging. And we take recourse to a balloon atrial septostomy only if they're very sick or if there's brain injury. And an atrial stent is sometimes used as a bailout in sepsis, as in these two infants who presented at 66 days of age and at 9.5 months, both of whom survived subsequently, and atrial stenting was done as bailout. So really the timing of surgery is a balancing act. The question arises, is the sepsis adequately treated? Will there be recrudescence following surgery? Vis-a-vis, how much will the left ventricle regress further while we wait? How do we identify a regressed left ventricle? Looking at the left ventricular contour and the shape of the left ventricle, as well as left ventricular mass, all of which have been elegantly described in literature. Not infrequently, there is delayed left ventricular involution, and this is due to scenarios of volume or pressure loading, which has again been discussed. And this allows for late primary arterial switch, albeit a postoperative transient and sometimes very profound low cardiac output state. The details of intraoperative and postoperative management have been very, very elegantly detailed in this recent article. Our intraoperative measures, in addition, include afterload reduction with phenoxybenzamine and elective siting of a PD catheter, as well as selective deferred sternal closure in view of the anticipated low cardiac output state associated with hemodynamic instability. How do we improve cardiac output? By well-described physiological maneuvers, which include preoperative preload optimization, afterload reduction, and taking recourse to adjuvant strategies like calcium infusion, physiological corticosteroid use, thyroxine supplementation for hypothyroidism, and the use of non-invasive ventilation for left ventricular dysfunction. We have found it useful to have a postoperative LCOS care pathway, which is really based on conventional modalities and where the mainstay of management is afterload reduction. So very often ventricles such as this in the postoperative period are managed just using conventional modalities along with methods to reduce metabolic demands in the form of analgesia, sedation, muscle relaxation, and controlled hypothermia. We have found that the intensive care course after late primary arterial switch at 50 to 100 days is highly predictable. And it's very important to recognize this pattern. In the first 48 hours or so, the infant is highly unstable. And by the third to fourth postoperative days, the baby is far more stable, permitting sternal closure and extubation. Surges in left atrial pressure are addressed by increased sedation or muscle relaxation and really low dips in blood pressure by increasing vasopressors like norepinephrine or vasopressin, physiological steroids, and calcium. Thereafter, subsequently, there's a rapid recovery with the median length of stay usually around 14 days. And by the time of discharge, the left ventricular function is invariably restored to near normal. The common pitfalls that we found that we should avoid are administration of rapid fluid boluses to this non-compliant left ventricle, chasing low blood pressures if the baby is well perfused, the administration of high-dose catecholamines, and premature extubation and sternal closure, disregarding this pattern. And so not infrequently, we often accept hemodynamics such as this on the 0 postoperative day, where the mean arterial pressures are as low as the high 20s. What about the use of mechanical circulatory support in late primary arterial switch? It's very variable in literature, and literature reports an elective to rescue attitude ranging from 0% to 33%. And recently, people have used the left ventricular assist device for regressed left ventricle in the postoperative period. What are our indications? Persistent or rising left atrial pressures, worsening metabolic or lactic acidosis. But a useful and emerging alternative we found has been the use of levosimendan for rescue, which we've been taking recourse to since 2017 when it was made available in our part of the world. What are our outcomes like? Between 2002 to 2019, 274 infants underwent primary arterial switch for transposition intact septum. You can see that the early mortality between both the groups as well as the mechanical circulatory requirement were really comparable. And only one infant died of left ventricular failure. So to conclude, late transposition intact ventricular septum is a problem in many parts of the world, more so in resource-constrained countries. Management continues to be an evolving story, but surgical options exist for most scenarios. And it's useful to adopt a highly individualized approach for surgical strategy and timing because this optimizes outcome. In the end, the primary arterial switch is indeed feasible with minimum recourse to mechanical circulatory support. And I'd really like to thank Professor Kirklin and the World University once again for giving me this honor and this privilege. Thank you very much.
Thank you very much, Parvathi. We have, that was incredibly informative, and we have time for one question that I see here. Is an interatrial communication important or detrimental for left ventricular retraining in the presence of late presentation of TGA intact septum?
We don't use a left atrial communication for left ventricular training. If a baby presents late, if he's otherwise not septic or having neurological injury, he goes straight for a primary arterial switch. The only time, and many of them who present late, usually you cannot successfully do a balloon atrial septostomy. So we've had a couple of patients where we've done an atrial stenting, and that was really as a bailout because they were so sick and we needed time so that we could stabilize the baby before we could take them up for surgery.
Great, thank you very much. So now we'll turn to the atrial switch procedure. Dr. Krishna Iyer, also from New Delhi, India, will discuss the atrial switch operation for TGA intact septum.
Thank you, Jim, for that introduction, and thanks once again to the World University for the honor of this invitation. Aren't we still stuck at the last slide? So I'll be talking about the atrial switch. The presentation outline will be a brief look at the history of the atrial switch, the current indications, talk about the technique of surgery, including a brief surgical video, talk about the long-term outcomes, and finally end with a take-home message. These two are the pioneers of the atrial switch procedure, Ake Senning and William Mustard, and they described the procedures which go after their names. Both ended up rerouting the circulation at the level of the atrium. The Senning procedure involved a series of creation of atrial flaps and thereby achieving the rerouting, whereas the Mustard procedure essentially took off the atrial septum and then established the rerouting by means of interatrial baffle. Historically, the Senning procedure was the one to be first described in 1957 and became popular because it was the first corrective procedure for transposition intact septum. However, when the Mustard procedure became more popular in the mid-60s because it was technically simpler, the Senning procedure fell into disfavor. It revived again in the mid-70s as the midterm results came out and the Mustard procedure seemed to have more problems than the Senning procedure. But then again, with the advent of the neonatal arterial switch procedure, the Senning again went into disrepute. And today, there are few indications that remain in the Western world for an atrial switch procedure. So the atrial switch, diagrammatically represented here, actually reroutes the circulation at the level of the atrium. It leaves the right ventricle as a systemic ventricle in comparison to the arterial switch, which is an anatomic correction because it corrects the defect at the arterial level. And therefore, the disadvantages of the atrial switch procedure, because it's still a physiological repair, leaving the right ventricle as systemic ventricle, which affects the long-term outcome because there is a significant incidence of right ventricular dysfunction, which can result from arrhythmias, and also issues regarding baffle obstruction. But the advantages are that it's a procedure that's applicable to all ages at presentation, unlike the arterial switch. It's a relatively lower risk surgery, needs lower intensity intensive care, thereby costing less in terms of hospital costs. And of course, over course of time, we've realized that certain modifications can potentially improve the long-term outcomes. And these are all the reasons why it retains appeal and the relevance in low middle income countries. We found that the addition of a loose PA band while doing the atrial switch procedure would potentially allow for gradual left ventricular retraining. And it's an important aspect because it minimizes the ventricular septal shift, which is one of the causes for late onset of tricuspid regurgitation and right ventricular dysfunction. So by putting in a PA band, we feel that we may improve the long-term outcomes with the atrial switch procedure. And in addition, it would allow for arterial switch conversion without retraining because the left ventricle would be retrained in the situation where the systemic RV ventricle would fail in the long term. More recently, Sir Mark D. Yakub published in the 2020 issue of Journal of Thoracic Cardiovascular Surgery, a modification to the Mustard procedure. And this is of relevance to countries in the low middle income economies. And he concluded by saying that the Mustard operation, particularly the modified technique, should play an important role in late presenting patients with TGA. Improving the patterns of left ventricular filling could enhance the long-term results. So the atrial switch procedure still retains importance in certain parts of the world. So what are the current indications? For the atrial switch, it of course forms a part of the double switch operation, the atrial component of the double switch. It is the definitive procedure for the rare condition of isolated ventricular inversion where there is atrioventricular discordance but ventricular arterial concordance. And as I mentioned, for late presenting transposition, it is an alternative to retraining the left ventricle and performing an arterial switch. And of course, in this part of the world, again, you get patients who've got advanced pulmonary vascular disease in either intact ventricular septum or ventricular septal defect. and the atrial switch is an option to improve saturation in these patients. And the same has been reiterated in the clinical guidelines for management of transposition, which was published in the European Journal of Cardiothoracic Surgery. All of them have a level class 2A indication. So our approach to late transposition, as has been alluded in the previous talk, what's important is that once the patients are beyond 6 months of age, our preference is to do a Senning procedure and apply a PA band instead of doing a rapid two-stage arterial switch procedure. So a look at data with the transposition intact ventricular septum over the last 20 years, a total of 407 patients ranging in age from 3 days to 15 years. 126 of them underwent a Senning procedure, and the primary arterial switch procedure was done in 281. But you look at the time frames, you can see here that before 2000, majority of the late presenters underwent a Senning procedure. But when you look at 2000 to 2019, there were far more arterial switch procedures. The current 30-day mortality for a Senning procedure is 2%. But this data highlights that in the early periods, early diagnosis of TGA-IVA was rare. So we rarely got a patient early in the 90s. But then also our learning curve for the primary arterial switch operation in late presenters has improved, and therefore we're more confident of doing a primary arterial switch in these patients. I go on to the surgical technique, and briefly, the patient after placement on cardiopulmonary bypass, the first is an oblique incision in the right atrium, which exposes the intraatrial septum. The next step is to create an intraatrial septal flap. The groove of Sondergaard is dissected, and if necessary, the atrial septum, if it's inadequate, can be augmented with a piece of pericardium or PTFE. The next step is to septate the left atrium with the intraatrial flap. So you create an anterior chamber, which is in communication with the mitral valve, and a posterior chamber. The systemic venous pathway is then created by suturing the lateral aspect of the right atrium. Going on to a surgical video, this is a patient with 6-month-old transposition intact ventricular septum. You can see the banana-shaped regressed left ventricle and the intraatrial septum going into the left ventricle. And looking at the surgical video, if you look at the steps, this is transposition, you can see the anterior aorta. It starts with extrapericardial dissection of the superior vena cava and inferior vena cava, a dissection of the Sondergaard's groove here. Then we make an incision into the right atrium parallel to the intraatrial groove. This runs from the upper to the lower end of the right atrium. Then the pulmonary venous atrium is opened widely. This is the most important step, that's creation of the atrial septal flap. And this has to be done by generously incising into the atrial septum boldly and not worrying about getting out of the heart, which often happens at this part of the incision. You can always reconstruct this with a few sutures there, but it's important to get a generous piece of atrial septum. It's preferable to use natural tissues. The atrial septum is sutured into the left atrial wall, both superiorly and inferiorly here along the posterior margin of the mitral valve. Then the systemic venous atrium is created. This is sutured both above and below. That's the IVC aspect. Once done, the trabeculae in the right atrial appendage are divided. So you get room for this right atrial flap then to be sutured. And we suture it to this pericardial well, which has been created. And this is important. That's why we need to cannulate the SVC and IVC extrapericardially. So once that is done, the pulmonary venous chamber is completed, which is quite roomy. And that's the end of the procedure. You can see the heart is now quite pinked up. And when you look at the postoperative echo, you can see that there is a nice pulmonary venous pathway, which is unobstructed, and a systemic venous pathway, that's the SVC blood coming to the mitral valve. So looking at some of the long-term results, the long-term outcome of the atrial switch procedure is not as dismal as has been projected. This early paper in 2004 from Belgium, showing the survival for simple Senning, the Senning performed for transposition intact septum, well over 95% in this group of patients. Looking at it more closer, results for the complex, that is transposition VSD, and transposition with other anomalies is certainly less. than patients with transposition intact septum who fare quite well in the long term. More recently, this is the total population study from Finland, again comparing a 40-year survival of all patients undergoing both the atrial switch procedure in the earlier era and the arterial switch in the current era. Again, although showing that there is a steady attrition in patients undergoing an atrial switch, but the survival is still reasonably very good, considering that these patients were operated in the early era of cardiac surgery. But with the Senning procedure, the survival is still over 80%. And this, when you exclude the initial operative mortality, which was much higher in this period, you can see that although there is an attrition, the long-term survival in these patients is still quite acceptable. So the take-home message that the atrial switch operation still holds relevance today, especially in low middle income countries where late presentation still remains a major problem. The long-term outcomes can be improved with technical modifications, and the long-term results do show that the Senning procedure is associated with better long-term outcomes as compared to the Mustard procedure. Thank you once again for the opportunity, and I'm open to questions from the audience.
Thank you very much. I think what we will do, just to keep us on track, we will go ahead with our next presentation. And again, if we have time at the end, I see a few questions. But right now, we'll move ahead with Dr. Kirsten Finucane from Auckland, New Zealand, who is going to discuss management of late left ventricular outflow tract complications following the arterial switch operation. Kirsten?
Thank you, Jim. Good morning, everybody. It's great to be here, although it is past 3 o'clock in the morning here, so forgive me if I yawn occasionally. But it's great to have a chance to talk about this. Now, my arrows haven't come up on here so far to be able to control. Oh, here we go. Yeah, got it. So as the survivors of the switch reach adulthood, I think we're starting to see problems in some of them with the evolution of neo-aortic valve regurgitation. And it's not easy to find out much about this surgery. There's not a lot of papers about it, but this is one good paper from last year from Tokyo Women's Medical University by Nakayama and colleagues. And they looked at 469 of their hospital survivors of both simple and complex arterial switches. And they found 17 patients who'd had to have surgery on the neo-aortic route. And of those 17 patients, 11 had had aortic valve replacement, 3 had had repairs, 2 had had conos, and 1 had had an aortic root replacement. And the average age of those 17 patients was 16.5 years. So there was that's a little bit of information, and this was their Kaplan-Meier curves, and on the left is the freedom from moderate neo-aortic regurgitation, and on the right is the freedom from neo-aortic valve surgery at 30 years. And the risk factors for reoperation haven't come up on this slide, but there were 3 that they found with multivariable analysis. And the first one was if there was any regurgitation in the pulmonary valve before the switch. And the second one was if there was any surgery on the left ventricular outflow tract or obstruction of the left ventricular outflow tract at the time of the switch. And the third one was at the end of the surgery when the patient was discharged, was there any neo-aortic valve regurgitation, even minor at that point? So those were their risk factors. They didn't actually find the technique of surgery to be a risk factor. So I had a look at our own results, and I guess I did this so that you'd see why I can talk about it a little bit. And in our own group in New Zealand, where we follow all our congenital patients, because not many of them escape, but they occasionally escape to Australia, but not many. We have 11 patients who have been operated on for neo-aortic valve surgery, and that's actually 6.7% of our 163 simple switches that we've done. And in fact, those are from back in 1987 through to 2010. I picked out those who'd had at least 10 years of follow-up after the switch. And we've done on those, all of them have had root replacements of one sort or another, including 5 that were valve sparing, 4 that were homografts, and 2 that were Bentals. And the reasons why we did the surgery, when you look at these patients, are variable. There are a varying amount of root dilatation, neo-aortic regurgitation, and LV enlargement and dysfunction, and they're mixtures of the 3 things. But we do serial measurements to see that root dilatation. We do measurements of the grade of regurgitation, and 8 of the 11 patients had at least moderate, if not severe. And we look at LV dysfunction, and sometimes these patients have not only got an LV enlargement, but they've got a disproportionate amount of dysfunction, even when they've only got moderate aortic regurgitation. And that also triggers us to operate. Preoperative investigations, of course, are echo, including a TOE to look at the mechanism of the AR, and MRI. The old operation note, so when we're planning the surgery, these are the sorts of things we need to look at. The old operation note, including the description of that anatomy. Did they do the Lecomte? Were there technical details or old injuries in that operation that were important to know? And then on the valve morphology, we're looking on echo for the LVOT and annulus size, but we're very specifically looking for aortic leaflet, movement, symmetry, and depth, because that's going to help us decide whether we can preserve the valve or not and repair it. And then we want to look at the coronary anatomy, and not just at the origins of those coronaries where they are now, but also the pathway of the coronaries. And so this is an indication on CT scan of the Lecomte maneuver. And so now the pulmonary arteries are in front of the ascending aorta. And of course, that means they're closer to the sternum. And here's a young man with an aneurysm of his aortic root. And here's the pulmonary arteries lying in front of the aorta. And of course, this up here is the innominate vein. And this is the access point to the ascending aorta where you want to cannulate. So these CT scans are very useful for preoperative planning. This is a CT of a coronary origin. This patient had the right coronary leading up and over the pulmonary root here, and an LAD coming off in the same sinus. But also, if you move on, you can see that for them, the pathway of the coronary is also very important, because this patient had their circumflex coming off from the right-sided sinus, but traveling around the back. Here's the pathway of it. And this is pretty important to discover, because if you were to try to do a valve-sparing root replacement on this young man that I did earlier this year, you could see that the sutures that you do down deep onto the aortic root here may damage this coronary. So you need to know about the pathway of the coronary as well as the origins. You also need to know about the RVOT, which you can find out from the MR, because you're going to divide it as you go to the ascending aorta. You need to know the detail of what's behind the sternum, which we use CT for, access for cannulation, and is there a residual septal defect? We usually do a bubble study on the table with pressure on the lungs. So the operative techniques include very careful re-entry, including access for groin cannulation, although we actually have only groin cannulated 1 of these 11 patients. The cannulation needs to be quite high on the ascending aorta. Often there doesn't seem to be a lot of length there. And you need room, you see, to get around the ascending aorta below your cannulation site for cross-clamp access. You need to divide the main pulmonary artery at the old suture line, and you can do this before you cross-clamp, so long as you don't have a residual septal defect, because if you have that, you may get air embolism across it on bypass. You peel the main pulmonary artery off the neo-aortic root, but watch out for the coronary buttons that are nearby. And once the aorta is cross-clamped, you can then open the root at the previous suture line, locate your coronary orifices, and open the anterior wall if you need to see further down. You don't always need to do that. That's just the dissection between the aorta and the PA. But this image is more useful, and this is looking from the right-hand side of the patient, low down. And here's the aortic cannula, and there's a cross clamp here. And these vessel loops are slinging up the pulmonary artery. It's now been divided, so these are the pulmonary artery branches in continuity being pulled upwards out of the way. And this is the aortic root that's now been opened. You can actually see the old suture line just there. And this is the stay suture holding the pulmonary artery root forwards and out of the way. So this is the initial opening of the aorta with the cross clamp on. And once that's done, you can then look down into the neo-aortic root and you get this view once you've completely divided the root. Here's a commissure, and this actually is a coronary button on this side. Then as you look further, you can get further down into the outflow tract and see the leaflets. But when you're first looking for an assessment for a leaflet, for a sparing operation, you need to look at the depth of the leaflets, the thinness of them, their symmetry. And one other important thing here in these patients that I've become aware of is that they often have quite a lot of muscularization. What I mean by that is that the hinging point of the leaflets is actually above, is below where there's muscle. So muscle from the LV is creeping up, if you like, into the sinuses. That makes it very difficult to get the valve sparing root down over the outside of the valve below the hinge point. And that makes it difficult to create symmetry in the new valve. So this is sometimes a reason, I think, why you can't spare these valves in these teenagers and young adults. When you insert coronary buttons, these are often in non-standard positions now. So it's useful to complete the outflow anastomosis a little bit like what Marcelo was showing us earlier, and then position your coronary buttons onto the root once it's filled, so you can see where they are, and make sure you don't put them so that they'll be under any tension or they will bleed when the heart fills up. I have had one of the 11 cases where I did a valve sparing route, but then on echo, the valve was not competent enough, it wasn't good enough. And then you can go back, open the outflow area, and put a mechanical valve inside your Dacron root. So you don't have to repeat your whole root replacement. You just put the valve inside. It's a roomy size. So that is a fallback for when the valve sparing root's not good enough. And if you put in a homograft, which we do quite a lot for our teenage population and young adults who want to play rugby or want to have babies, the native tissue around the outflow tract needs to be preserved really carefully because it makes it easier to reoperate when you come back to do their Bentors later on. So here's what the LVOT looks like once you've removed the leaflets. And these are the coronary buttons, left and right on each side, now mobilized upwards a little bit so that they can go into the homograft once it's inserted. This was a young man who was very keen to keep playing rugby, a very good rugby player. He was 120 kilos too. And this is what the LVOT looks like as you look down into it. So you, with work, you can actually get a very good view of the left ventricular outflow tract and really perform whatever surgery is indicated for that patient. Nakayama showed some sobering longer term outcomes for his 17 patients who had neo-aortic valve surgery. So their survival does tail off and their reoperation rate is quite high. But in 17 of his 17 patients, 11 patients had valve replacements rather than root surgery. And I'm not so certain that perhaps some of those might have done better by having the root replaced at their surgery. So finally, for our patients, the outcomes have so far of those 11 patients have been good. 2 patients with homografts have had Bentors. one of them only after 13 years of a homograft and a successful pregnancy. So in conclusion, late neo-aortic root surgery is needed in a small proportion of switch survivors, somewhere between 3 and 7% perhaps. The selection of procedures is similar for a native root. I think you can do any of these procedures, but you do need to have a careful operative strategy, allow for the congenital morphology, and obviously be very familiar with congenital repairs. Results can be excellent if the surgery is done in a timely way. So huge aortic roots are very dangerous and scary to operate on. I think you should be certainly thinking by the time they're 5 centimeters that you get on and do them. And obviously also if the LV is starting to fail and the ejection fraction is going down below 50%. So we should counsel parents initially that there will be a need for long-term follow-up for their teenagers and young adults, and that some of them will end up with aortic valve replacement. Thank you.
Thank you very much, Kirsten. There's one question I see that wants you to comment whether you routinely do the Jakub or the David type of valve-sparing root replacement.
One of the patients is a David. Sorry, one of the patients is a Jakub early on, and I think that was a patient who had an eccentric sort of aortic root, so I don't think I could have done a David, and the rest were all David procedures. But sometimes you do modify it a little bit because of that muscularization thing, and you can't get one side of the tube, of the Dacron tube, down all the way.
Okay, thank you very much. So we'll now go on to Sertash Chikek from West Virginia University School of Medicine. And Sertash is going to talk about management of the right ventricular outflow tract complications following the arterial switch.
Hello, Jim. I really appreciate the opportunity and a great honor being part of this World University program, the first program. And I will be talking about the right ventricular outflow tract complications of the arterial switch procedure. As arterial switch operation first reported by Dr. Jatene in mid-1970s, it soon became the major operation for arterial transposition of great arteries. As A.K. Senning, who was one of the pioneers of atrial switch for transposition, affirmed that arterial switch operation will be the gold standard and a real anatomical correction in 1987, and it really became the operation of choice. In fact, arterial switch procedure has become one of the best practice indicators for pediatric cardiac centers. However, despite the enthusiasm, during the last decades, several papers started to raise questions about the true long-term outcomes of arterial switch procedure. If we focused on the long-term survival, the answer is certainly yes. Many centers reported long-term survival comparable to normal population. If you eliminate the early attrition, which is less than 1% on advanced referral centers now, the long-term survival of arterial switch procedure is very comparable to normal population. And this paper reports from a single institution, a 28 years follow-up, showing excellent survival after the early attrition rate for arterial switch procedure. However, if you look at the event-free survival, this is not the situation, and more papers now coming out with both regard to early, mid, and late need for reoperation and reintervention for arterial switch procedure. As you see on this graph, over 20 years, there was a significant number of reoperations addressed for different problems related to arterial switch procedure. As you see on this graph, at 24 years, the need reoperation period survival from an arterial switch procedure is as low as 40 centers on overall 40% on a few centers. Is ASO an anatomical correction? So looking at the results, we can affirm that the expectation has most limit with regard to the survival, but arterial switch procedure is not 100% anatomical repair as it has been described on many papers and by many speakers. There are structures that are definitely different from normal heart, and especially surgical manipulation that made different, that resulted in different geometric configurations, resulted in disadvantageous outcomes. There are different levels, such as great vessel anastomosis and relationship of great vessels to each other, right ventricular outflow tract problems, on long-term neo-aortic root dilatation and function, and coronary perfusion. I will focus on right ventricular outflow tract problems of arterial switch procedure. First of all, an arterial switch operation does not establish normal cardiovascular geometry. Spiral configuration of aorta and pulmonary artery outlets are lost due to the Lecomte maneuver. New pulmonary trunk are compressed between the sternum and ascending aorta, and it becomes more oval shaped, and flow patterns with anterior translocation of pulmonary trunk changes and results in increased vertical flows. And again, due to this geometric configuration, it has been shown that right pulmonary artery gets most of the flow. This is an important paper which uses 3D hemodynamics on MRI study. As you see on the right side of the left side of the screen, this is a healthy volunteer patient showing normal flow patterns on the ascending aorta. B and C shows transposition patients. This one on the B shows a right located truncal pulmonary artery, and this one with a centrally located pulmonary artery. Evaluation of post-surgical hemodynamics here revealed increased vertical flows on anterior pulmonary trunk position and asymmetric flow with increased systolic flow patterns on the branch pulmonary arteries. Here on this centrally located main pulmonary trunk, you see the transition of left PA vertical flow, which shows non-laminar flows and abnormal flow patterns after arterial switch procedure. This is another MRI study, studying the mechanisms of branch pulmonary artery stenosis after arterial switch operation. This one on the left side shows a centrally located ascending aorta and then new main pulmonary artery draping over balanced on a balanced way both on the right and left sides. However, on the right side of the screen on this B, you see main new pulmonary artery translocated more to the right side with stretching of the left pulmonary artery and having less flow. This cardiac catheterization post-stitch procedure shows a main pulmonary artery stenosis, which is most likely related to early technical problems and could be addressed much more easily. However, it is very well known that neopulmonary artery stenosis and pulmonary arterial problems are significant early and midterm problems of arterial switch procedure. The reasons for this problem could be on two levels. The first level is technical issues related to incorrect great vessel transaction, insufficient pulmonary artery mobilization, and material used for pulmonary artery reconstruction, such as autolog fresh pericardium or ultralight fixed pericardium or bovine pericardium. As Dr. Jonas described very nicely, I believe the technical issue is one of the main prevention areas for long-term avoidance of right ventricular outflow tract problems, and it requires use of generous pericardial patch and leaving enough anterior native pulmonary wall for growth. However, there are anatomical issues that might affect the development of outflow tract problems, right ventricular outflow tract problems, and these are again the presence of side vessels, anterior coronary loop, ascending aorta flow obstruction, small LVOTO to RVOTO, and small central pulmonary arteries with collaterals. This paper was recently published from Poland, analyzing over 715 cases and reporting reoperations and catheter interventions on arterial switch procedure. Again, another one from Munich between 1983 and 2014, 688 patients operated for transposition of great arteries with an arterial switch procedure. And 11 persons, 79 patients developed right ventricular outflow tract obstruction at a median of 3.8 years, and they found that the side-by-side great vessel anatomy, presence of arch anomalies, use of a pericardial patch, and any gradient over 20 millimeter mercury at discharge were significant factors for development of right ventricular outflow tract obstructions. Again, this paper by Dr. Hazekamp and colleagues from Netherlands analyzed the risk factor for reoperations for right ventricular outflow tract obstruction after arterial switch procedure. And they found that the tau signaling anomaly has the largest risk, 5.5, to develop postoperative right ventricular outflow tract obstruction. Again, a deviant great vessel arrangement, complex arch pathology, and anomalous coronary pattern were the significant risk factor for development of right ventricular outflow tract obstruction following arterial switch procedure. Once developed, treatment is necessary, and the goal is to improve right ventricular pressure, provide symmetrical blood flow to both lungs, and prevent low flow of distal pulmonary hypoplasia. And indications, although are not very well defined, mostly the indications for any right ventricular outflow tract obstruction on guidelines has been used. Any peak RVO2 gradient over 50 millimeter mercury, and any gradient with a depressed RV function constitutes indications for right ventricular outflow tract intervention. This paper was published by Iowa group, and they reported the results of catheter-based interventions for supravalvular pulmonary stenosis after the arterial switch operation, and reported that the benefit of balloon angioplasty procedures for left and main pulmonary arteries, as seen here, are not favorable and shortly temporary. It should be noted that although interventional catheterization and catheter-based interventions today are used for first-line percutaneous intervention on pulmonary artery stenosis after arterial switch operation has high risk and should be undertaken advisedly. And prior thorough evaluation of coronary arteries is mandatory, as coronary implantation sites may be adjacent to sites of pulmonary artery stenosis. This paper by CHLA group reporting the results for arterioplasty of right ventricular outflow tract following arterial switch procedure reports that the time interval between ASO and echocardiographic diagnosis of significant RVO2 obstruction was 12.5 months, which shows an early timing for operation. And this early development might be related to, again, some technical, surgical technical issues. And 64% of the obstruction were at supravalvular PA level, 42% at branch PAs, 12% was valvular, and 3% was subvalvular level. Surgery constitutes most patch arterioplasty, and if needed, sometimes an infundibular transannular patch. However, all areas of potential stenosis needs to be augmented, and any subvalvular obstruction needs to be relieved at the operation. If again we ask the question of if arterial switch operation meet the expectation, it's surely that even if determinate subsets of patients still have slight risk of death and reoperation, and again, right ventricular outflow tract problems with the incidence of 10% are the most frequent problems we see after arterial switch operation. And the treatment should be started primary operation with prevention and delicate arrangement of pericardial patches with a generous pericardial patch and enough anterior native pulmonary artery, I believe, is the key factors to prevent such problems. A combined collaborative transcatheter and surgical approach is essential. again, once again, a benefit of interventional pulmonary angioplasty at the main pulmonary artery and LPA shown to be temporary. I thank you for the opportunity and privilege of presenting at this inaugural meeting of World University. Thank you.
Thank you very much, Shirtesh. We will now go on to the final presentation. Dr. Igor Konstantinov from Melbourne Children's Hospital, Royal Children's Hospital of Melbourne. And he will talk about long-term outcomes focusing on survival following the arterial switch operation. Igor? Igor, you may be muted if you want to see if you can unmute yourself.
Can you hear me now?
Perfectly, thank you.
Okay, perfect. As I said, in Melbourne, we always use a trapdoor technique, and this is a very permissive technique. And this is how Roger Mean started arterial switch operation in Melbourne, and we do exactly the same all the time for every single patient with no exceptions. And I often tell our cardiologists that the less you tell me about coronary anatomy before surgery, the better. Because we approach every single arterial switch as if there is intramural coronary. And as Marcelo mentioned before, intraoperative inspection is far more important than anything else. And we have good results. And more recently, not to enlarge ST junction. And by the way, we never implant coronaries above ST junction. We do the same trapdoor technique, and then we approximate ST junction above the coronary button. And do we have long-term coronary problems? Well, just let me revisit a little bit anomalous coronary artery anatomy, which is common in, reasonably common. It's about 1/3 of patients would have it. And it was alluded today in previous talk that single coronary artery is a problem, and intramural coronary artery is a even bigger problem. Well, we recently published a paper on intramural coronary artery. You do exactly the same. We identify intramural coronary arteries, and we unroof intramural coronary artery. We divide in between and then do standard arterial switch operation. The very first early procedures, 3 of them, they had implantation of a single button, and the rest were all standard arterial switch operation. And just guess how many intramural coronary arteries we diagnosed before surgery? I tell you, 0. So inspection is far more important than any preoperative echocardiogram. And the outcomes, there were no operative or late mortality, and no reinterventions on the coronaries. Freedom from all reoperations in these patients was 93% at 19 years of mean follow-up. And recently we published a more extensive study looking at about 1,000 patients from Melbourne and Brisbane. And in Brisbane, they used a trapdoor technique as well. And in 1,033 patients operated for 30 years, we identified, yes, there is a higher early mortality in patients with unusual or abnormal coronary artery pattern, but not statistically significant. And there was also higher rates for post-operative mechanical circulatory support, very low rate of coronary reinterventions. And this is early mortality. So overall mortality was 3.3% for the entire cohort. Yes, it is somewhat higher in abnormal coronary artery, but again, not statistically significant. And when you look at intact ventricular septum, overall mortality was 1.6%, again, somewhat higher for abnormal coronary artery. And similarly, it was somewhat higher, but not statistically significant for patients with VSD. And all the mortalities happened early. Long-term survival was excellent, and there was no late death. Well, reintervention for coronary artery stenosis. Interesting topic, and we wanted to study it, but the study pretty much ended here, because we identified that among 1,033 patients, 6 patients had reinterventional coronary stenosis after operation, and 5 of them during the same admission, only 1 late. So it would be difficult to study intervention stenosis in this subgroup of patients. Causes for reinterventions. Most common cause for reintervention in our group of patients, as we published in 2012, was pulmonary artery stenosis. Near aortic root dilatation, as we all know, is common. Up to half patients after arterial switch operation, they do have near aortic root dilatation. And I saw on the previous slide.
Tudo bom? Obrigado, viu? Até mais, amém, tchau.
It's almost universal, but big problem. So far it has not been. Now we recently published a paper on aortic arch obstruction. And yes, patients with aortic arch obstruction, they do have higher reintervention rate overall, both on right side and left side. In Tausig-Bing anomaly, freedom from reintervention was 75% at 15 years, and freedom from moderate or more aortic insufficiency was 91% at 10 years. And this is a paper that we published about 10 years ago. Well, long-term outcomes in children less than 2.5 kilos. Operative mortality was quite high. It was 19% in these patients, but again, it all happened in children less than 2 kilos. No late deaths. Freedom from reoperation was quite low, 60% at 20 years. So this is a high-risk group patient. And this is a paper that is under review now, hopefully will be published soon. And if you look at survival, at 25 years, we had 95 patients who survived to 25. And 25, in those patients, we saw that 15% of patients, they either moderate or more near aortic valve insufficiency or had undergone replacement of near aortic valve. So yes, it looks that 25 to 30 years, we will see more and more patients with aortic root dilatation and valvular insufficiency who will require surgery. And Kirsten mentioned very important thing that very often LV dysfunction is disproportional to degree of aortic insufficiency in this, and it is yet to be identified the reason for this is yet to be identified. We don't know why, but we also observed it. Well, of course, in Tau-Sig-Bing anomaly with aortic arch obstruction is over-exaggerated problem. So it causes long-term high risk for reoperation on RVOT and high risk of reoperation on aortic root and aortic valve. Well, in Tau-Sig-Bing anomaly, what we do, well, we use this modified coronary button transfer with trapdoor, and often we resect trigonal piece from non-facing, non-coronary sinus, try to decrease the diameter of near aortic root after arterial switch operation. Well, and of course, in Tau-Sig-Bing with side-by-side arrangement, we have to implant main pulmonary artery into the right pulmonary artery, and this creates very long left pulmonary artery, which is stretching itself over the aortic root. And hence, many of those patients will require subsequent patching of the left pulmonary artery and resection of RVOT obstruction. Well, long-term outcomes. Look at intact ventricular septum. Well, at 20 years, roughly we have about 80% of freedom from reintervention of any sort. VSD, lower. At 20 years, it is below 75, so it's approaching 70. Then Tau-Sig-Bing anomaly without aortic arch obstruction is not bad. When we look at patients with aortic arch obstruction, look at this. At 20 years, half of them would have reoperation. Well, I skip this arterial switch operation after atrial conversion because we don't see those patients anymore. And overall, if you look at 20 years, freedom from reintervention is about 75%. So we have a quarter of patients who would have reintervention of any sort. In terms of freedom from near aortic root or valve surgery, it was, well, it was 94% at 20 years in the papers that we published 8 years ago. And it was quite low. But now, as patients get older, we see more and more patients like this. And we all enlarged aortic root is a problem. And this is a spectrum of congenital heart disease, and patients after arterial switch operation, they have almost universally enlarged aortic root. Is it a problem? Well, do they ever dissect? I've never seen dissection, never heard of dissection after arterial switch operation. But aortic insufficiency in longer term means 25 plus years, will become a problem. And what do we do about it? Well, aortic insufficiency is almost universally due to dilatation of the root. So classical Robichik RAB could be used, well, or more recently, we have a personalized external aortic root support, which has been taken over earlier, which is 3D printing individualized root, and it could be wrapped about around aortic root to decrease the diameter, and it is actually quite effective in reducing aortic insufficiency without replacing aortic root. And of course, if aortic root has to be replaced, then David or Jakub or Florida sleeve could be used effectively. And in conclusion, well, small subset of patients require aortic reoperation for pulmonary stenosis or near aortic root or valve problem long-term. Challenging subgroups, as we all know, anomalous coronary arteries, aortic arch obstruction, Tau-Sig-Bing, VSD, low operative rate, and of course long-term follow-up for this subgroups is needed. And my feeling is that 25 to 30, even more at 35 years follow-up, we will start seeing more and more problems with this knee aortic root and RVOT obstruction. Thank you.
Great. Well, thank you very much, Igor. And this brings us to the conclusion of our webinar. I want to thank all of our esteemed colleagues for sharing their expertise today, and to all of you for joining this webinar. I want to remind you that this webinar was recorded and will be available for viewing up to 30 days. A link will be sent to all the registrants by email so that you can access this. And again, this is the first of what will be a monthly webinar series for the World University. The next scheduled webinar is on October 31st, covering the core aspects of tetralogy of Fallot. So thank you all very much for participating, and have a great weekend. Bye-bye.
Bye.